A stroke that is caused by a blocked artery in the brain is called an ischemic stroke and is the most common form of stroke. When a cerebral artery becomes obstructed, typically by an embolus, blood is unable to reach a portion of the brain. This lack of perfusion results in the sudden onset
of impaired neurological function.
Signs of an embolic stroke: fast, droopy or asymmetrical facial expressions, impaired or asymmetrical arm movement, slurred or unable to comprehend speech, and timely management or treatment of emergency services of the patient experiencing a stroke. Neurological deficits include weakness of limbs, confusion, dizziness, and nausea. Impaired level of consciousness occurs during the initial 24 hours if comorbidities occur, for example, elevated intracranial pressures, brainstem stroke, and seizures. Functions deteriorate if no intervention occur, for example, motor activity, bowel and bladder elimination, intellectual function, spatial perception, altered sensory abilities, mastication, swallowing, and communication. Right-sided embolic stroke. Signs and symptoms include left motor paralysis, impaired left spatial perception, and short attention span, and deteriorated decision-making skills. Left-sided embolic strokes include right motor paralysis, reduced speech, comprehension, and problem-solving abilities, difficulty with deducing right from left decisions, and conscious to deficits, as well as anxiety and depression. Underlying anatomical and physiological reasons for deteriorated abilities. Impaired motor functions includes 5 facets, including mobility, respiratory function, swallowing, and speech, gag reflex, and self-care abilities. Observable defects of an embolic stroke episode includes impaired skill, voluntary movement, reduction of integration movements and alterations in muscle tone, and reflexes.
Airway management is essential at preventing further brain injury. It allows for the oxygenation of brain tissues. Although it doesn't correct the damage caused to the ischemic site, it can restore some of the surrounding tissues. A great way to have worse injuries from your ischemic stroke is if your airway is not managed correctly, or if you have an airway obstruction. Head tilts, jaw thrusts both elevate the tongue from the posterior pharynx. They are actions used to help maintain an airway. Ventilation and oxygen therapies assist in the administration of oxygen to the patient. It is proven to be effective at supporting patients undergoing an ischemic stroke, especially in those with a reduced level of consciousness, hypoventilation, aspiration pneumonia, keen strokes, and also helps with high intracranial pressure.
Surgical interventions. There are some surgical interventions that can be used to treat an ischemic stroke. The carotid endarterectomy aims to reduce the risk of stroke by eliminating stenosis of the carotid artery. Basically, vascular surgeons can open up the lumen of the artery and remove the plaque and debris obstructing the blood flow. Although this surgery can be successful, it is a high-risk surgery, and there is calls for further research about the safety and efficacy of the procedure. As they remove the plaque, the blood flow, when it's restored, can be quite rapid and can actually cause brain edema and hemorrhagic transformation, which can quickly develop, and this can be quite life-threatening. Likewise, the utility of the surgery is restricted, as the events of an ischemic stroke can happen very quickly. Alrighty, so alimentation is basically the management of nourishment, and it's critical for helping someone recover from an ischemic stroke. Poor nourishment can greatly extend their recovery time. So, why is it so important to consider nourishment? 45% of ischemic stroke patients have a reduction of fluid and food intake because of their dysphagia. 40 to 60% have a swallowing defect. These defects can include things like dysophonia,
abnormal gag reflex, and impaired voluntary cough. So it's no surprise that 16% of these patients had nourishment defects. So what are we going to do? We can firstly refer them for a swallowing assessment, and basically they test things like oral labial closure, a gag reflex, if they have a wet voice after swallowing, and then they can also perform a water swallow test. We can see if they're going to aspirate on foods and things like that. And of course, aspiration is bad for recovery. If their swallowing is impaired, which it probably is, we can pop them on nasogastric or PEG tubing, and this is a method of enteral feeding, and it's a method of supplying nutrients directly to the gastrointestinal tract, and it's for patients who have an impaired swallowing ability.
In order to diagnose embolic stroke, there are 3 different procedures we can use. These include a GCS, CT scans, and MRIs. The Glasgow Coma Scale, or GCS, is a formal assessment used by health professionals to help diagnose and assess the severity of a stroke. The GCS is a 15-point system used to monitor eye, motor, and verbal responses to external stimulus. A low or decreasing score on a GCS is an indicator of high intracranial pressure, which is usually provoked by brain swelling, referred to as cerebral edema. Causes of cerebral edema links to types of stroke such as embolic or hemorrhagic in nature. Results in GCS can determine the severity of the stroke with a GCS of below 7 is an indicator of poor prognosis, while a GCS of above 7 will have better patient outcomes. The Glasgow Coma Scale is a reliable tool used in the medical profession to help diagnose strokes, which can help us provide more further examination like CT scans or MRI. Magnetic resonance imaging, which is also known as MRI, is the most accurate method to scan and diagnose embolic strokes. MRI looks for clots and blockages in the brain. They do this through the means of using contrast or dye, magnetic fields, and radio waves to generate images. Computer tomographic without contrast, or as we know as CT scans, are one of the most common tests used to diagnose embolic strokes. Since the most common indicator of strokes, if embolic or hemorrhagic in nature, is that the brain starts to swell, causing intracranial pressure, also known as cerebral edema. When a CT scan discovers cerebral edema and no signs of hemorrhagic stroke, the medical or surgical interventions can be commenced. Unfortunately, CT scans are not as accurate as MRIs, but they're currently faster and they do not use dye, which can be harmful in hemorrhagic strokes. This is why CT scans are used as gold standard to detect strokes today.
When an artery becomes obstructed by an embolism, rapid intervention to dissolve the clot is essential. So how is this achieved? The first line of treatment is the use of a powerful antithrombotic called TPA. This is a clot-dissolving drug, and it stands for tissue plasminogen activator. As a tissue plasminogen activator, TPA catalyzes the breakdown of a blood clot by activating inactive proteins inside blood clots called plasminogens, which TPA converts into an active enzyme called plasmin. Here's a diagram of a blood vessel obstructed by a blood clot. Blood clots are made up of a fibrous, sticky protein called fibrin. Plasminogens, the inactive proteins, are entrapped within the strings of fibrin, which make up a clot. TPA binds to the fibrin and converts these into plasmins, enzymes which have the ability to dissolve the fibrin which forms the clot. TPA is administered intravenously and must be given within 4.5 hours of the onset of symptoms, so timely intervention is vital. A patient undergoing TPA therapy is at a very high risk of bleeding, and so is contraindicated in patients with any risk of bleeding. It is essential that the cause of the stroke is established to be ischemic rather than hemorrhagic. If the patient is experiencing a rupture in the brain, TPA should definitely not be used, as it will only worsen the symptoms. Because of this, TPA is only to be administered by a physician experienced in its use. Once the clot is dissolved, patients are placed on prophylactic medications, such as anticoagulants. The most common anticoagulant used is low-dose aspirin. It's effective, cheap, and readily available. It works by inhibiting the aggregation of platelets. Aspirin is known as a COX inhibitor, as it inactivates an enzyme called cyclooxygenase. This enzyme stimulates the formation of lipids, which facilitate vasoconstriction and platelet aggregation to coagulate blood and form clots. By inhibiting the production of this lipid, platelets are less sticky and are therefore unable to adhere themselves to one another to form a clot. For acute conditions, the initial dosage of aspirin recommended is usually 150 to 300 milligrams. However, use of aspirin long term should be taken at about half the dosage, 75 to 150 milligrams daily, which we call low dose aspirin. Antihypertensives such as perindopril, an ACE inhibitor, are also very commonly used in stroke rehabilitation to decrease blood pressure and lower the patient's risk of further circulatory complications. ACE, or angiotensin converting enzyme, converts the hormone angiotensin 1 into angiotensin 2. The hormone angiotensin 2 stimulates the production of antidiuretic hormone and aldosterone, which promote water and salt retention in the blood, as well as stimulate thirst to increase blood volume. Additionally, angiotensin 2 is a vasoconstrictor, causing blood vessels to narrow. These mechanisms result in an elevation in blood pressure. Therefore, inhibiting ACE means that angiotensin 2 is not produced, and so these mechanisms to increase blood pressure are stopped, reducing hypertension. In summary, ischemic strokes are treated by dissolving the blood clot, restricting perfusion using an antithrombotic, TPA, and anticoagulants and antihypertensives are used to prevent future complications.